Hi everyone, my name is Dr. Victoria Pope, and in this PowerPoint I am going to be going over basic EKG interpretation with you. Over a series of a couple different PowerPoints, we're going to look at some basic principles, and then we're going to look at rate and rhythm, and then we're going to talk about infarctions and talk about some pearls along the way that you will benefit from in primary care. So let's start with some basic principles. What is an actual electrocardiogram? Well, an electrocardiogram is a very common diagnostic tool that we use to record the electrical activity of the heart. It gives us important information about what is going on with the structure, the function, as well as the rate and the rhythm. What it is recording on that EKG graph paper is systole and diastole, which is the electrical process by which the heart is contracting. Systole is depolarization, it's the actual contraction that we see, and diastole is when the heart relaxes and repolarizes. And all of that is recorded on that EKG, 12-lead EKG or a single EKG strip. Now, when we get a 12-lead EKG, we place leads on various aspects of the body, and then we view this active depolarization and repolarization on the EKG paper tracing. And we'll see upward and downward deflections, and we'll talk a little bit more about what each one of those means, depending on what lead we're looking at. So this slide shows you the conduction system of the heart, and some of you may remember this quite well from anatomy and physiology. But basically, if you look in the right atrium, you'll see the SA node. That is our pacemaker. The SA node sends an impulse that travels down the internodal pathway and then comes down to the AV node, where there is a brief pause before it travels down the interventricular septum, all the way down and comes up into the bundle branches and the Purkinje fibers and stimulates contraction in the ventricles. So when this happens, this depolarization and repolarization, we see, like I told you, those upward and downward deflections on our EKG paper. And let's go over a little bit about what we will see. So when the SA node fires, we begin to depolarize our atrium. This is where the atrium will contract. And we see this as our P wave on our EKG recording. Once that impulse reaches the AV node, which is the second picture on the left, you see, like I told you, there's a brief delay at the AV node, and we get that isoelectric line that you see in green. As it continues to travel down, the atrium are repolarizing, and the depolarization begins in the septum and then works its way up into the right and left ventricle. And that's where we get our QRS complex. When that depolarization is complete, we have another pause, and that's where you see the top right, that isoelectric line, before repolarization begins, causing the T wave that you see at the end. Once this whole process is complete, then another impulse begins and we have the process start over again. And that is our actual EKG complex that we're looking at. This is another slide that you can pause and look at and read in more detail that goes over that again, and then also shows you some of the intervals that we look at. You see the P wave in the first picture, which is atrial depolarization, and then the second picture in the top middle is showing you your PR interval. And each of these intervals should be a particular length. So anything beyond that is some kind of issue with conduction, and we're going to talk about those different kinds of blocks and things that we may see along the way. So we may see a PR interval that's longer than it should be, and we'll talk about what that is. That's a first-degree block. We may see a wide QRS complex. We call those bundle branch blocks, and we'll talk about those. And then we want to look at our ST segment. That's where we would see ischemia or injury occurring, ST segment. T wave is ventricular repolarization, and then we have what we call the QT interval. The QT interval is really important to remember. A lot of medications may prolong that QT interval, and a prolonged QT interval can predispose you to some pretty lethal arrhythmias. So we'll talk about that a little further along. So this slide is showing you how we record that EKG. The EKG is recorded on this graph paper that most of you have probably seen. Each of those small boxes are 1 millimeter by 1 millimeter, and 5 of those boxes are what are comprised within the heavy dark boxes. So each of those bigger boxes are 5 millimeters by 5 millimeters. And when we look at these deflections, they can go upwards or downwards. We record them in millimeters. So if you look at over to the right, you'll see the amplitude is recorded as 3 millimeters high or 2 millimeters deep, depending on the direction that it's going. And when we look at our ST segment, which is really important when we're looking at patients with cardiac injury, we also measure that ST segment in millimeters. So when we look at the horizontal axis, not the vertical axis, but the horizontal axis, we can determine the duration of each part of the cardiac cycle, that time interval that we're talking about. That we do in seconds. So for example, this slide is showing you the PR interval. That's from the beginning of the P wave till your R wave begins, and that normally is 0.12 to 0.20 seconds. That's a normal PR interval. If it is longer than that, then we call that a first degree block. Now this is your QRS interval. A QRS interval is normally 0.08 to 0.12 seconds, and anything above that is considered abnormal. So if you have something above that, then you are probably looking at some kind of right bundle or left bundle branch block. And I'm going to show you further down in another PowerPoint how to determine whether you have a right or left bundle. And then this is the QT interval. The QT interval is usually less than 0.5 seconds. Like I told you in the previous slide, if it's prolonged, it can predispose you to lethal arrhythmias. The most common cause is medication interactions, although there could be some congenital causes. And a pearl to remember here is that your QT interval should be less than half of the R to R interval. And R to R interval means from one QRS complex to the next. So that QT interval should be less than half. And I want to show you some of the medications that can prolong the QT interval. And you can see that a lot of these are medications that you may be prescribing in primary care, whether it's an antibiotic, an antidepressant, and your patient may present to you already on some of these medications like an antiarrhythmic. So it's important to be aware of the QT interval and the medications that can prolong it. And now we're going to discuss the 12-lead EKG and how we obtain the 12-lead EKG. The 12-lead EKG is comprised of 6 limb leads and 6 chest leads. When we put the electrodes on the left and right arms and left foot, we're able to get 6 different recordings on the EKG. Basically, it's 6 different angles that the camera is looking at the heart. So first we'll talk about lead 1, lead 2, and lead 3. And what I want you to just remember from looking at these is where you see the positive electrode think of that as where your camera lens is sitting. So for example, if you look at this picture at lead 2, the positive electrode is on the foot, on the left foot, and the negative electrode is on the right hand. So that camera is looking up from the bottom to the top of the heart. Just like lead 3, you're looking up. And lead 1, you see the camera would be on the left hand looking across to the right. So the positive electrode is where your camera is sitting and it's looking towards the negative electrode. So this is lead 1 and lead 2 and lead 3. We also, from these leads, can get what we call augmented limb leads. This is AVF, AVR, and AVL. And these leads are looking at the frontal plane. So the augmented leads use the same electrodes as the limb leads, lead 1, 2, and 3. However, the negative lead, the one that the camera is looking towards, it's basically in the middle of the heart is where we're looking. So when you look at your AVF, you see your camera is pointing up to the middle of the heart from the very bottom, and AVL and AVR are coming down from two different angles. And all this does is give you another perspective that you're looking at. So as this applies to cardiac injury, if you look at your camera, lead 2, 3, and AVF are all looking at the inferior aspect of the heart, which is why when somebody has an inferior wall MI, you see ST elevations in lead 2, 3, and AVF. So it's just making that connection. We also have 6 chest leads positioned around the chest. We call them V1 and V6, and they provide us with a visualization of the horizontal plane. So this shows you the position of V1 through V6, and basically you're looking at the front of the heart. You see that? And the lateral side of the heart. So anterior and lateral. And this just shows you the 2 different planes and where you would have all those leads positioned to get exactly this, the 12 lead EKG. And I think I'm going to stop there, and we'll start the next PowerPoint. We'll look at rate and rhythm.